Okay, so we're just past the hour here. So, and we've got 13 people. Well, I think maybe some of those are AI bots, but we've got
Mhm.
enough people on, I think, to start going. So I'm the chair of the ISA board, and Sue is the secretary of the ISA board. So we're both going to co-host this meeting today, and we're delighted to welcome Dalitso. Dalitso, I'm not even going to attempt to pronounce your surname, but you can do that for us. And a warm welcome to everyone who's joined. Dalitso is going to tell us about her research. Dalitso, I'm going to just hand straight over to you. Please introduce yourself. I think you're a relatively new member of ISA, so just tell us a little bit about yourself and then go straight into your presentation. Thanks.
Thank you very much, Paula, and thank you everyone for being here. My name is Dalitso Ndaferankhande. That would have been a very hard one. And I am a first-year PhD student at the University of Birmingham, but I am from Malawi, the warm heart of Africa. And I'm very passionate about this work, and I'm hoping to contribute to the growing knowledge to better support parents, especially in low-income settings where support is still very underdeveloped. And I'm glad to be here. Thank you very much for this opportunity. And so I'll jump into my
Yeah,
presentation.
go ahead. You can share your screen. Thanks, Dalitso, for the great introduction. We're really looking forward to hearing from you. I'm delighted to have someone presenting from Malawi.
Great. Can you
Great.
see my screen?
We can. Can you get it into presentation mode?
Yeah.
Yeah.
All
Sometimes
right.
it's a bit tricky that with sharing.
All right. So the title of my presentation today is Death Remains with You: How Beliefs and Practices Shape Parental Mental Health After Perinatal Loss in Chikwawa, Southern Malawi. And as I said, I'm Dalitso Maluza-Ndaferankhande with the Malawi Live with Welcome program in Malawi, but currently a first-year PhD student at the University of Birmingham. So in this presentation, as part of my overview, I'll be going through the introduction. I'll give you a rationale for the study that I undertook in Malawi 2 years ago, and then looking to the key findings around the beliefs around perinatal losses, the common practices from this area in Malawi, the exclusion of fathers and how this impacts on the mental health experiences of parents after perinatal loss, and what the key takeaways are from my presentation. So the World Health Organization, just some background information, the World Health Organization defines perinatal losses as a combination of stillbirths and neonatal deaths. So stillbirth being deaths of babies from 28 weeks, and neonatal death for babies who have died in up to the first 7 days of life. And as you can see from the numbers, 2.6 million annually of stillbirths take place, and of which 90% take place in sub-Saharan Africa, where Malawi is located, and also in Southern Asia. The stillbirth rates are very high in this region, and as you can see, that Malawi's stillbirths are they're within the range of the high Southern African stillbirth rates. Neonatal deaths are the same in that close to 22.5 million neonatal deaths take place annually every year, and 80% of these take place in sub-Saharan Africa, where Malawi's stillbirth rate is slightly higher than the sub-Saharan Africa. So perinatal losses occur significantly in sub-Saharan Africa, and this is why we should be paying attention to the mental health outcomes that come from this as well. The rationale for my study that I undertook in Malawi was to understand what the bereaved experiences of parents was. What the literature says is that bereaved parents experience common mental health disorders such as anxiety, depression, and grief. And these common mental health disorders can persist up to 2 years following the incident of loss. Persistent and managed common mental health disorders in the perinatal period, so from pregnancy to the first year, can lead to several challenges, including a high risk of maternal suicide, which is actually one of the leading causes of maternal deaths in the perinatal period. The other challenges which take place as well for parents who've experienced a perinatal loss, some of them are also social challenges, which include isolation, difficult relationships, and also divorce. In a study recently talked about that divorce was underlined as one of the social factors which takes place, especially in low-middle income countries, because of the status of births and parenthood that is predominant in the area. Narratives around perinatal losses can be very harmful, and some of these narratives that are in literature are as follows: that babies who are born stillborn are non-human. They're defined as things and as strangers to the communities. They're caused by spells of evil spirits, God himself. So there's an issue of fatalistic nature that something's going to bound to happen, and also witchcraft. And sometimes this is also blamed on the mother's promiscuity. What has the mother done? And as a result, also maybe she was also, this stillbirth has happened because she's trying to have an abortion. As such, the stillbirth neonatal deaths are met with rushed burials and a prohibition to mourning. There's some literature which describes studies done in Kenya where mothers have been said to be cautioned against crying and saying, if you do cry, this will bring on more calamity in subsequent pregnancies. There's also been a rejection by husbands and in-laws because of these perinatal losses, and also generally a lack of social support and healthcare support. So this is literature is there. It's very limited, but is there around perinatal losses, especially in low-income countries, many of which are found in Africa. And so my study took place, this is a photo that I took of the district hospital in Chikwawa. Chikwawa is a rural district in Southern Malawi. And with my study, I was trying to explore the psychosocial experiences of parents bereaved by stillbirth and early neonatal death in this area. My participants were 10 bereaved mothers and 6 bereaved fathers. And this was exciting because fathers rarely do accept to take part in conversations around perinatal losses. And as you can see also the differences between 10 mothers who accepted and 6 of their partners who did. And also 12 religious leaders, community leaders, and also faith-based leaders, including female chiefs, took part in the focus group discussion to try to understand what happened, what the experiences around for parents in this area. And the sampling was done purposefully, so looking into working with community leaders to identify parents who've had a loss and approaching those parents and finding out if they're happy to take part in this study. So what were the key findings from my study that took place in Chikwawa? I'll start with highlighting some of the beliefs around perinatal losses, and I want to do this by taking some of the direct quotes from the participants themselves. And I would largely just put these in 3 groups. There are lots of things that people talked about, but largely 3 groups. One, it has to do something with the mother. A perinatal loss has to do something with the mother. And it could be the mother herself who has blamed herself. And this is a mother talking, saying, I was drinking a lot of cold water, especially from the freezer. I think maybe the unborn baby caught a cold because of the cold water, and maybe that influenced it to stay idle. So that's a mother also blaming herself. There are aspects of, from a female birth leader who said there are some people where this stillbirth is related to the disease she had during her youth days, that she was promiscuous. Again, this has been found in other literature about promiscuity, supposed promiscuity of mothers. And this is a female chief who talks about that women, especially women who've had multiple stillbirths, are called bringers of death. The one who experienced the two stillbirth is one who's called Echimfafa. So I've just taken the initiative as well to put some of the actual language from Chichewa here, and it says who's called Echimfafa, which is someone who's a bringer of death. Imfa is death, and Chimfafa is the bringer of death. Other dominant narratives around the beliefs of perinatal loss are that they're spiritual. So either that God is in charge of bringing this loss about, or there've been other spiritual causes. So this is from someone saying that, and looking at today, and maybe you might want to exchange. So this is a father who's talking about how what was spoken to him, and said maybe you want to exchange your baby for rituals, or else so and so has sacrificed your baby for rituals. This was not a good thing to hear, and I decided to stop socializing with such people. I no longer visited such social places. So there was a common belief, especially for fathers, as I'll discuss later, that they sacrifice their babies to get rich. And then there's also the aspect of community healthcare negligence, which was also one of the very big factors around the causes of stillbirths, in that this community leader says, I'm looking at today's life of being glued on the phone. You find that the woman is complaining while the doctor is busy on the phone telling her, if the time is near, I'll let you know. At this point, the woman's ready to be delivered, yet the doctor is busy on the phone. So there's a lot of conversation around healthcare negligence, the spirituality, and also around the mother being the cause of this perinatal loss. So some of the common practices that happen in Chikwawa district following the perinatal loss is that whatever time the perinatal loss happens, whether it's midnight or in the morning, a burial takes place immediately. And this is usually women-led burials. They're rushed, and so on the way to the gravesite, the baby is strapped to a family member who carries the baby to the gravesite, and women help dig shallow knee-high graves in Chihuahua district. While at the burial site, this is in this area where they have senas, it's a tribe. This is one of the rituals which take place, and this is a photo that you see at the beginning of the presentation. One lady talks about her experience, and she says, this is done after we have already done the burial. And when we're about to come back from the gravesite, they pick up small sticks saying, Salanako kufa kwako, remain with your spirit of death, while throwing these sticks at you. So a mother would have her hands open, and these women will place these sticks in her hands, saying, death remain with you. Everyone who's a Sena from this tribe and is escorted you to the gravesite gets to do that. Senas believe that they do not have to get close to anything, get in close contact with anything at the funeral. If that happens, it means death can happen in their homes as well. I have stayed within the Sena tribe before, and my second child died while still there, and people tend to isolate you like you're not a human being because of their belief. After the funeral has taken place, some of the post-burial rituals, this is a photo that I took from the internet, but some of the post-burial rituals are to do with taking of traditional medicine. So traditional healer has a very important role to play after perinatal losses. As perinatal losses are deemed to be spiritual, perinatal healers, traditional healers are very crucial in one trying to identify who has bewitched you, trying to prevent such bewitchment of taking place again, and also cleansing you from what has happened to you because of the perinatal loss. So female chief says, if we take the traditional medicine, then we wait for some days for traditional medicine to work efficiently in our bodies before resuming life, and also in this context before resuming sexual relations as husband and wife within this area. So before you can resume normal life, there's an aspect of undertaking these healing rituals to cleanse, to protect, to identify who could have been the possible cause of the mischief. And another tribe as well explains one of the rituals that they do after the death. So this ritual is called Gloa Kufa, and it's done a week after the baby has died, when they assume that decomposition has started taking place. So this woman is explaining that during the moment of intimacy with husband and wife who have been bereaved, that means we need to have a pot of cooked relish, either vegetables or meat, in our bedroom. And this time our parents are also waiting, and they cannot be intimate with each other since they're waiting on us. That means in the morning we need to dish out the cooked food, which was in our bedroom at the time of intimacy, and give it to our parents. And after they have eaten, that means they have also done Kloa Hofa. So again, a lot of rituals going around cleansing, around doing these necessary steps before you can resume normal life, so to speak. And I also want to highlight that part of the rituals is the exclusion of fathers. Fathers predominantly do not take part in any of the rituals, except I think in Muslim deaths, where if the baby was a neonatal death, then fathers are the ones who, men are the ones who go to the gravesite, as explained to me, because they said that this baby is human because the baby cried. So if it's a stillborn, again, it's mothers who take part in this area. And generally, fathers are excluded from going to the gravesite, from even visiting the gravesite afterwards. And so these are some of the quotations from the fathers that Anna highlight. Father number 3 says, there was no other man that came around. It was only women that were available. This showed that whatever was happening there concerned only women as such, and the men had no room to attend. Even the funeral service was going on, the men still had no room to be available. So the physical exclusion of men is very predominant in this area. And another father, number 6, says, because this is all about culture, men not attending the burial ceremony, and there's nothing I can do. Had it been that this was not set, I was going to ensure that men took the role of digging the grave, for example. Whenever an adult has died and was buried, we never got the news that a grave where a corpse of an adult person was buried has been excavated. But I feel the children's graves are usually excavated because they're inappropriately dug. So again, referring to the knee-high graves that the women dig. As such, we just assume that maybe some people will later go and excavate the corpse. And then lastly, brief number 5 says, it is a hard restriction to take because as a human being, I want you to know where my child was laid to rest. So fathers really, really highlighted that not being part of this and the society culture seeing this as a woman's issue when it's actually both men and women who are affected is something that played a big role on their lives. So now having heard about the beliefs and the practices, how do these impact on the mental health experiences of parents? Mothers, primarily from my study, have experienced a lot of self-blame, blaming themselves in terms of, I must have done something wrong for this to have happened, and also community. The community has a way of also blaming mothers with the narratives around prenatal losses, something you could have done, something from your past you're trying to abort. So mothers are hearing these voices at the time of one of the lowest times in their life, and this primarily gets internalized due to the lack of information that happens from healthcare providers in this area, maybe just due to the lack of diagnostic tests, very limited healthcare providers and expertise generally in this area. Investigations into stillbirths rarely do happen. And so fathers leave the hospital not knowing what's happened, what caused the baby's death, and something maybe vaguely shown to them. And because of this lack of information, issues like self-blame and community blame do take a great role in the negative experiences of mothers. There's also name calling. So if you've had a recurrent pregnancy loss, especially, you are called a Jimfafa in this community, someone who brings death. There's a stigma attached to also prenatal losses in that if you've had this, then no one can come close to you because you could possibly the spirit of death could possibly go into other people's homes. And also there's a social issue of social isolation, that you cannot take part in community activities until the aspect of cleansing has taken place, which can be socially isolating. Another mother had explained about how you can't even go to the community borehole to take water because people would assume then that they can catch the spirit of death from you. So it's a completely isolating experience, and for mothers. And for the fathers as well, the fathers' voices are predominantly very silent in experiences of prenatal losses. There's a very big assumption that a prenatal loss only happens to a mother. And this is also what's been highlighted in my study, in that fathers experience great emotional turmoil. There's sadness, there's anger at also having to, they called it like a failed investment. Fathers usually take a part in making sure that the baby has the necessary equipment, blankets, clothes, when they're being born. So when a stillbirth happens, the fathers were very angry that it felt like this was a wasted investment, a wasted aspect of putting financial things. And so one of the surprising experiences that fathers have talked about, and I talked to 6 fathers, and 4 fathers talked about suicide ideation. that they wanted to commit suicide. They wanted to leave their wives, their villages, because of the ridicule that again takes place, that impacts on the fathers being blamed for taking part or possibly sacrificing their babies for rituals so they can get rich. And so the fathers also experience a lot of exclusion, a lot of powerlessness in not being able to take part in giving their children honorable deaths. And I, like from previous slide, I talked about how fathers were had wanted to at least be able to take part in digging graves so that the babies had dignified deaths. In this scenario, in this situation, in this community, the incidents where babies were excavated by people, want to do rituals, also even things like or dogs, stray dogs come and excavate because the graves are very shallow. So fathers felt that this was very humiliating. This was very unrespectable way of honoring the babies. And so all these experiences really weighed heavily on the fathers. So as I'm wrapping up, I just wanted to just explain how the beliefs and the practices around perinatal losses, both for mother and the fathers, they play a profound, big role in negatively impacting parents' mental well-being. So both fathers and mothers experience profound psychological distress. And because it's an area that it's still under-researched, we're not looking at the moment to measure distress in parents. And also, if we're not looking to measure it, we're not looking to manage it. So both parents from this study do experience both psychological distress, and fathers are psychologically affected too, contrary to the beliefs that fathers are strong or they should be strong. But fathers in this study have said that we are psychologically affected by these deaths to the point of wanting to commit suicide because they're also socially excluded from taking part in the mourning of their babies that they're prepared for. Cultural norms and beliefs can worsen psychological outcomes, as we have seen, especially by blocking the mourning expression, by having rushed burials, by having fathers excluded from the deaths, by not explaining what causes the death, or even having rituals that have to take place before you can be integrated into society. Sometimes this can take a week, sometimes it could take months, depending on the tribe as well. So these aspects of cultural norms and beliefs that can worsen and the impact of fathers and mothers' well-being, and also the lack of medical information as a takeaway is very important because this can cause fear and also can reinforce the harmful beliefs around perinatal losses for parents as well. So social practices can also cause stigma, isolation, and also disenfranchised grief, where the grief is not recognized in the community. Contrary to adult deaths, for example, where community comes together, there's an announcement that death has happened. With the baby's death, the only women are the ones who take control. They do the burial and it's very rushed, and mothers and fathers do not have a time to grieve, properly acknowledge that this is a loss that's happened in this community, and also especially for our family. What should happen next is that we need context-sensitive multi-sectoral support to better support parents after perinatal loss. Support needs to take place right from the health sector, healthcare providers, as they are the main or the first point of contact for both parents. In the communities, we need to be maybe rethinking about how we can how we can change aspects of our rituals, our practices to incorporate also fathers, and also to allow for this death to be recognized in the community. And this is what my PhD right now is looking into, finding out how we can best better support parents following perinatal loss in Malawi. And there is a cyclical influence around beliefs, practices, and norms, which unless we take the initiative at the community level to start questioning these, to start rethinking them, then the narratives around perinatal mental perinatal loss, the negative impacts on parents will continue because the beliefs inform the practices inform the psychological outcomes, and these outcomes inform the social outcomes and reinforces the beliefs. And it's a circle that needs to be broken. It needs to be rethought, and it needs a lot of careful consideration for many parties to act quickly and also to act sensitively to reshape and to rethink about how we can better support both parents after perinatal loss. So thank you very much for your attention.
Fantastic. Thank you so much, Dalitso. That was really interesting. Great. So invite everyone who would like to put on your cameras, and anybody got any comments or questions for Dalitso? Just go ahead.
Amazing. That was so good. Yeah.
Yeah. Super interesting. I think quite a few people here work in Africa, or come from Africa. So please go ahead. Yeah.
It was just really cool to hear such amazing cross-cultural references that we don't. I'm from Australia, so it's so interesting to hear about those beliefs that we just wouldn't hear about.
Yeah.
Thank you.
But I think it's quite common across many African countries.
Yeah.
And I think probably maybe slightly different, but across many Asian countries as well and others communities. Dalitso, did you find that when you were doing these interviews, that you were able to, were they open to receiving other information about, the causes of stillbirth or newborn death, that it's not their fault, and that do they understand that these beliefs are actually not true and harmful? Did you have discussions with people when you were doing your interviews?
I think after the interviews, because primarily my interviews to try to find out what the research, what they think without having me to explain some aspects of this. But people were very open to wanting to find out what are the causes of stillbirths and asking me what some of the causes are. Though the aspects where people wanted to find out how they can be supported. What some of the fathers actually did say that I wish, because in Malawi we do have in communities we have what we call male motivators. So these are men who've experienced maybe a maternal. They're usually used in like to promote safe motherhood. And one father said, I wish we had someone like that who's experienced a loss, who can tell us what to expect and how to grieve for this child. Because, they said that this is seen as a women's issue. And I would want to know what's happened and how I can prevent this from happening next time. Again, because fathers said this was like, we wasted money. And you can imagine these are very poor people who've put their coins together to support this baby that was coming along the way and the baby dies. So there's an aspect of where did we go wrong? The hospital didn't tell me what happened. And because of that, then I'm forced to believe that it was so-and-so who bleached my baby and things like that. So I think that it just shows that the information that's given in the community needs to be counteracted by some medical information to better support parents as well.
Absolutely, yes. Vivian, you have your hand up, and then Sue, I saw you raising your hand. Vivian, go ahead.
Oh, sorry, I didn't even realize I was on mute. Good morning, good afternoon, good evening, everyone. Thank you so much, Dalitso, for sharing that amazing presentation. I totally relate with everything that you have mentioned there, and it's interesting how all the aspects are very common in most of the African communities. I come from Kenya, and everything that you mentioned was very, very relatable and usual practices that happen when there's a stillbirth, especially the cleansing practices, the women being alienated, and often trying to find the cause for the loss. And I actually had a question for you. Did you have maybe a section where you talked about, or rather, did you experience any influences in healthcare seeking behaviors after a stillbirth? Did women now, maybe most of them, do they go back to the hospital, or do they now turn to traditional birth attendants or home births? Because already the stillbirth is associated with some spiritual, in quotes, factors.
Thank you very much, Vivian.
Did you experience any of that? Yeah, go ahead. Thank you.
Yes, no, thank you very much, Vivian. And that's, I mean, some of the studies that I've been looking at actually have been from Kenya and Uganda, and I've seen some similarities, as you have discussed. I think what the study highlights is that there is a dual system in seeking healthcare even after stillbirth has happened. There's an aspect where they believe that because it's spiritual, then let me also go, and they do primarily go to a traditional healer, especially after stillbirth has happened, to possibly prevent this from happening, which I think there is room for the medical, for Western medicine, should I say, to lead in this area, because I think if mothers or parents are primarily going to traditional healers, there could be a condition that is making a mom maybe have recurrent stillbirths that could be picked up in the hospital. So I think there's a way that both systems could work together, for Western medicine to acknowledge that our patients will also go to a traditional healer, but when they do go there, let them go there with the proper information, because what does happen if you only go to a traditional healer is that you foster, and you hear that so-and-so has bewitched your baby, it's your sister, your mother who's bewitched your baby, then it fosters hatred amongst, which only just makes the experience even worse, more even isolating. So I think there is room for both systems to work together, to complement each other, and even for community members to be able to say, you need to go to the hospital to get better help. So some women did talk about that they would go primarily to a traditional healer after a loss. Others did say would go back to the hospital. So it's still very mixed, and because it's still very mixed, I think there's again room for both sets to work together for better outcomes, especially because also traditional birth attendants they're not legalized in Malawi anymore. Before, they used to be there helping mothers give birth, but now it's in most villages it's been made a crime for you to give birth in the village. So, and you can get fined for giving birth in a village. You have to give a goat or whatever it is because you are late to go to the hospital in an effort to promote hospital births. So it's still very interesting, and I'd like to find out more from other parts of Malawi as well, as I'm assuming that there will be different cultures as well, which will be dominant.
Thank you,
Vivian.
Dalitso.
Yeah. Sue, did you want to add something there?
Yeah, and then I see Nicole. Dalitso, I'm wondering if you have gotten pushback. You mentioned that people kind of receive the information pretty well in Malawi. I'm wondering if you've gotten any pushback in the UK with your PhD from the Western world in terms of why are we trying to push our culture on the Malawians' culture. I don't get any of that in Uganda, but I get that here in the US. Who are we to be telling them that they should be practicing differently? And it's hard for me because I see this stigma. Of course, we want to change the stigma for women, and I see them grieving their stillborn babies if they haven't been shown their stillborn baby and things like that. But I get that on occasion here in the Western world. And I'm wondering if you've gotten that at all, like, why are you trying to change this for these Malawians?
Thank you, Sue. I think that's interesting. I guess this is my first platform that I'm sharing it from this to an international audience. Previously, I shared it only, so far I've done it after I made a presentation about this in Malawi. And though it was more intrigued to find out that these are the cultures which actually take place within the country that this still happens. And this is me presenting in town, and this is what's happening in the rural areas. So I haven't had that kind of pushback as to why we could be possibly imposing this. And I think for me, I'm hoping that my research doesn't come across as trying to impose anything, but trying to highlight that these are the experiences that are taking place for some mothers and fathers in this area in Malawi. It's a small area, but it's still taking place there. And maybe if my research was broad across the country, to be able to say that this is a very common experience, to generalize and say this is a common experience, and we should be thinking about how we can work together as healthcare providers, how can we work together as community members to rethink some of these cultural beliefs. And I'm saying this with confidence, saying that we do have we do have harmful beliefs, for example, in other areas. So around child marriages in Malawi, and those things are being reshaped. And I'm confident that when we begin to talk about that these are the beliefs that are happening and this is how harmful they can be for parents, then maybe it could also raise some flag to say, can we be rethinking this? Do parents need to be, is it necessary to have barriers which are rushed? Should fathers be excluded? And try and find ways, because it's being done in other areas, and be rethinking beliefs and practices. Can we do the same thing as well for perinatal losses?
I think your words of reshaping and rethinking are really, really good in helping people kind of think, about that. I think those are great. I just was curious because of some of the experiences that I've had. Thanks.
Thank you.
So Nicole, go ahead.
Probably another jump in.
Yeah.
Oh, thank you.
Hi. Hello? Can you hear me?
Yeah, we can hear you.
Okay, great.
Go ahead.
Hello, everyone. Thank you so much for this wonderful presentation. I'm sorry, I'm in transit, so I'm going to have to stay off camera. I wanted to go back to something. This is probably more of a comment, but I wanted to thank you for highlighting the experiences of fathers. And I am wondering if you might be able to say a little bit more. I know that what I heard was that there were some that were so distraught about the death of a baby, it gave them suicidal ideation, if you will. So I'm just wondering if you might speak a little bit to that.
Yes, thank you very much.
Sorry, and I had another. Sorry, this was the question. I forgot about it. And I'm wondering if that the way in which they felt about the loss had anything to do with the number of children or their ages. I don't know if you're able to share anything, but I'm just very curious.
Thank you very much for your question. And I just wanted to highlight that pregnancy, childbirth is still very, I guess, in the way it takes place in Malawi, in this community, is that a mother who expected mother will go to the hospital with her sister, a mother, a female relative. And when the loss happens at the hospital, fathers are not there. So fathers only hear about this with a phone call. They get a phone call which says, we have lost the baby. What should we do? It's more of a thing of a decision-making factor, like, we've lost the baby, what should we do? And it's about, do you bury the baby at the hospital, or do you take the baby back to the community for the immediate burial? And so that's how fathers first hear about this loss. They're not there when the baby is born. They only hear about this news, and they have to make such decision at that point. So when fathers were talking about suicide ideation, they talked about one, being ridiculed and being blamed, that especially for the fathers who are very well-to-do in the community, being blamed that you are the one who's caused this baby, you have sacrificed this baby to become rich. One father who was slightly elderly, more in age, and also had other children. This was his last child. He was also feeling very ridiculed, and also, communities are so small, and if you hear gossip from someone, it comes to you, say, this is what's happening. And fathers had felt that they couldn't do it anymore. They wanted to leave the community, they wanted to kill themselves, just because of this blame that was being placed on them. I wasn't able to make such an analysis as to find out if the fathers how many children they had, but all fathers had previous children as well. So the demographics of the parents or fathers all had living children, and they also had this stillbirth, which still brought about this emotional turmoil on their lives. So I think which just highlights that irrespective of how many other living children you have, the impact of a stillbirth is still very personalized. It's still very individualized to that baby that you're expecting that has passed on, and you need to grieve them.
Thank you, Dalitso. Nonku, you've got your hand up. Over to you.
Thank you so much, Dalitso. This is very insightful and very relatable. I just wanted to, well, I'm one of the mothers who are actually taken to a traditional healer, and because I was young, you know, I had to follow family process and everything, and grieve according to how the family wants me to grieve. I just want to find out, with regards to healthcare providers having or forming some sort of communication and relationship with the traditional healers and the religious faith leaders, how is that in Malawi? Is it something that's being established, something that's being discussed, especially for the parents and the betterment of the healing process? Yeah.
Thank you, Nonku, for your question and also just highlighting some of your experience. In Malawi, the systems are very separate. Whatever happens in terms of if you're gonna go the traditional healer route or your faith-based route, that's up to the families, and it's actually families, senior members of the family who organize that for the parents. I did have some parents. I think there was a couple who didn't go through the route because of their faith. So they were Christians, so they decided that we're not going to go through the route of taking medicine. And when I asked them, did they have any consequences of the family? They said no, because this is what we decided to do as a family. And others, it's the fathers, the mothers who actually are the ones who initiate that, oh, maybe we should go with a child who's been bereaved to so and so for some traditional healing. So it's a very separate system in terms of that. As soon as the baby has died, even at the hospital does give you an option of what you want to do in terms of the burial. So there's a place in the specific hospital where you can bury there's a graveyard for babies, so you can bury the baby there, or you can take the baby home. But that's where the care ends, so to speak. Unfortunately as well, this is another topic, but when I was speaking to the healthcare workers about their experiences, they said that it's harder to support parents because as soon as a mom or parent leaves after a stillborn, they're not coming back even a week later for their scheduled checkups, because they think, if I don't have a baby, should I still go back for a checkup? And so lots of parents are lost to that after support from the medical, and that's where only support usually ends as soon as the baby has died and they have been discharged from the hospital. That's as far as the hospital goes in terms of providing care afterwards. Whatever happens afterwards is usually depending on the individual families and their personal beliefs.
Thanks very much, Dalitso. Odessa, you've got your hand up. Go for it.
Hi, everyone. Hi, Dalitso. It's nice to meet you. My name is Odessa. I am from Kenya, and honestly, I really relate with what you said. For me, it's not a question. It's just a contribution to whatever you said, because it has really taken me back.
Wow.
I started my nursing career. That was in 2011 when I nursed a mother who actually had 17 pregnancies. So she was married early. She was married early. I think that was around 15 years. I trained in Western Kenya. So the family was trying to raise money for the family. So the girl was married off to a rich family. Unfortunately, she had So 17 lost pregnancies, that is, some were miscarriages and some were stillborn. So I met her at a point where she was really down. She was telling me she doesn't know what to do. She doesn't know where to go to, because now her in-laws were telling her that she's now feeling the area, the land that they were supposed to be cultivating with bodies. So you can imagine they really wanted her out of the family. And she's coming to me asking me, what do you think? What do you think I can do? You know, you're just a young nurse trying to find your path, and you get this kind of person, and you're like, my goodness, I wish I could do something more to them. And the other thing you talked about was they were not supposed to cry. And it's true. When you cry, you're told that you're going against God's will. So you can imagine a person, you've lost all these babies and you're still told not to cry. Honestly, this broke me. I think it broke me more than, I don't know what to say. So for me, you've just taken me back, and thank you for this. Thank you.
Thank you. I don't know if I can have a question for you, Odessa, just to learn as well.
Yeah, sure.
That, especially talking to healthcare workers, where you are aware of maybe the cultural beliefs, like don't cry and things like that. How do you balance that with what you know now as a healthcare provider in supporting parents?
Okay, so I think I take this personal. I won't say that there's a policy for you not to cry with them. Personally, I have cried. I am a neonatal nurse working in Kenyatta National Hospital. I have cried with mothers because they're these babies you've walked. I mean, you've walked with them. They were born preterm, like 28 weeks. You've walked with them. They're now 3 months in the unit and they die. So we actually cry with them. We walk with them the path. Like you cannot say, okay, I do not know this lady personally. This is work. We just try to, if they need spiritual help, we call what are they called? The chaplaincy to come and even, baptize the dead the dead baby. So we go with them the long way, as much as they allow us to. Yeah.
That's important. Thank you for what you're doing.
You're welcome.
Yes, indeed. It's a very tough job to be. I worked when I qualified as a doctor. One of my first jobs after intern year was in a special care baby unit, and I can only confirm, Odessa, it's incredibly traumatic because it very often happens, sadly, that babies die, and then and as you say, sometimes you've been on they've been on the ward with you for months and months, and of course you become close to these parents, especially the nurses do become very close to the parents, and it's really heartbreaking for everyone. So but we we need to work with healthcare providers and with village leaders to help them to help people and to be there for people and to be empathetic and try to help them through this process, as it's so difficult. Vivian.
Thank you. I actually want to kind of like flip this on the other side. I'm wondering, Dalit, so from the cohort that you had, did you have any mention about maybe supportive cultural practices that they experienced? Because I know that there is also that other side of support and love and just being encouraged to mourn and grieve. We have some communities in Kenya where they usually just take care of the mother. They come in with food, they're singing, they're dancing, they allow you to grieve. They just take care of you, for the 40 days. I know especially even the Muslims kind of do that for 40 days. They just take care of you and bring you food and nurture you, which I think is one of the good cultural practices. And I think there's also like a space for that some of these practices that are good, we need to really protect them because they also just help families feel supported through their healing journey. Did you experience any of that?
Yes. So that's a very good comment, Vivian. I did, but it wasn't as common. Some others did talk about that after they experienced the loss, some neighbors would come and would help them draw water, bring the water to them, and help them do chores. Maybe in the week, 1 or 2 weeks leading after the loss. But and others, I think, as much as those stories are important, they were much rare to hear about that than the ones where I felt shunned. I couldn't go out and things like that. It could also just be these specific group of mothers, how they were found. Again, it would be better to do a larger study to be able to generalize. So I can't generalize just from these very limited participants, but it was a mixture. It was a mixture. Some people found some help, others found that they were shunned even from the church, and others, some churches were able to, where in the funeral they do burials, so sing. Other members of the church member helped them sing. So it was very varied in terms of the responses from the community. And I think what would be good is to be able to hear stories like those and say, actually, it really does help a mom or parents if you do rally around them and help them with their chores. And I'm glad you mentioned something like 40 days. I didn't come across, for example, having a fixed barrier time. So again, it varies. So it would be nice to have those kind of, if we're to go the route of community support, what would that look like? Can we say that for the next 40 days, people around them rally and bring food, and irrespective of how the baby died, or those would be the good things to discuss further and to see if that happens more broadly across the country. These happen more for adult deaths. So in adult deaths, you do have people rallying around you. They bring condolence money. When it's a neonatal death, they don't bring condolence money. So again, it's that differentiation between adult versus neonatal. It's all death, but one is a human, the other is not, not yet, or they're strangers are passing by, whatever ways people find of describing them. But it'd be great to have more of those positive sides of culture come up in conversations. Yeah.
Thank you for sharing. I think sometimes also when one is grieving, maybe things that hurt them more are the ones that really tend to be at the fore because they're already hurting, and the things that probably they don't resonate with or they expect to be supported in a different way, maybe that's what shows up more. But thank you for sharing. I think there's a space for also sharing the positive support as well. Thank you. And also maybe just to add on to your presentation, thank you for bringing in that aspect that you also had religious leaders in your cohort, for them to bring in their input, because they're really people that the community listens to, and they have various insights because they interact with many families. And that was powerful. And also just the mental health aspect, because the lack of support, or support that is not really great, can lead to mental health issues. And there's a very thin line between grief and mental health issues. And sometimes you don't even know when someone crosses on to the other side. So that was a great aspect that you brought out. Thank you for your presentation, Dalitso.
Thank you, Vivian, for your comment.
Great. We have another hand up. Is it Jess from Millennia Psych? You've just got
My name's Lil.
Lil, sorry, Lil.
It's my work platform.
Yes. Go ahead, Lil.
So I was wondering if couples if they seek out like a medical sort of reason for their stillbirth, and if they are able to get one, if they are then comfortable enough sharing that with their community, does that lower the stigma or lower labels like witchcraft and sort of those spiritual connotations?
I think it could, and let me say that as an answer. I think it could. Number one, when I asked parents if they had gone back to, if they'd asked the health workers what caused their death, they said they didn't get back to me. I didn't ask. So one is having parents being empowered to know that they could ask that. And of course, I'm talking about this in light of understanding that our healthcare systems are already overburdened, and we don't have this the
Yes.
tools to, so there's that in mind. But in another work that I was previously, I was working in promoting safe motherhood, and we did do something like that where we called them community audits, death audits. So when a baby had died in the community, or mother had died, a baby had died, the community worked together with the healthcare team to identify what happened, what are the factors which led to the mother dying, what are the factors which led to the baby dying, and then the healthcare team will be able to come back to the community. They conducted community meetings in this area, and we told them that this mother died because maybe she was late in seeking support, or this baby died because this was whatever factor. It wasn't a way of pointing fingers at either the community or the healthcare, but it was to highlight that there are different factors which take place in what could cause deaths, and what communities could do better, and what the healthcare providers could do better. And when we did do those death audits, there was a lot of engagement, both for community and healthcare, but those are working together. And in doing that, I can see how now, if we're to have this aspect in stillbirth, how that could actually improve outcomes. Because when you don't have answers for things, your mind fills them up. It's God, it's whatever it is. But when you do have medical, when parents leave the hospital and they say our baby died because of asphyxiation or whatever, and they explained in very layman terms, they're able to bring this to the community members, to the senior people in the communities, and say this was happened. And therefore, I think it gives less room for narratives which are baseless.
Can be harmful.
Yeah.
Thank you.
Thank you.
Thank you, Lil. Yes, great question. Great. So I've just put the link from our website to the Parent Advocacy Toolkit, which was actually developed in Kenya. And we would love, people to try it out and have a look at it and give us feedback, because, we really want it to be used and adapted to different settings and added to, improved. So we'd love you to have a look at it and give us your feedback. And I see there's a question from Jessica Matowo in the chat. I don't know, Jessica, do you want to speak? Otherwise, I can read it out.
Hello, everyone.
Hi.
Hello.
Hello, how are you, Lisa? This was a very good presentation. I really enjoyed your presentation. Well done. However, I've got a question. What community strategies are in place in Malawi to address these cultural myths, beliefs, and practices vis-a-vis the mental health issues that the grieving parents can face after losing their loved one?
Thank you for that question. And again, I'll just highlight that I can't generalize because it's just it's a very small percentage for the study. But in that setting, I haven't come across any community strategies in trying to address this. And I think part of that is because we don't see that there's a problem. There's not a lot of discussion that's taking place to try to find out what the experiences of parents have been in Malawi, and also maybe other similar settings, because it's still a stigma, still a taboo to talk about these kind of deaths. And so I think because we're not talking about it so much, we do not know that there's a problem. We do not know that this could potentially lead to issues around poor mental health for both parents. And because we don't know that, then I think it's hard to come up with strategies, which is what I'm hoping to do now for my PhD, because this was my preliminary work. And so for my PhD, I'm actually looking to find or to adapt a community intervention, a community-based psychosocial intervention to better support parents. And in doing that, I want to be able to go back to communities and say, and have a discussion, because previously I was just taking information from them, but actually go back and say, how do you find these losses? Have mothers and chiefs and community people come together and discuss these things, and to say there could be a challenge in how we are doing this, and are different ways of how we can reframe these narratives to better support parents. So I think that the question is, I haven't come across any, and it could be because we don't come across them as harmful yet.
All right. Okay, thank you very much. You know, you've inspired me also to do some research. I'm a Zimbabwean working in Mozambique. So I really want to know context-specific problems that we are facing in Zimbabwe vis-a-vis and the grieving parents. Thank you so much.
Thank you, Jessica.
Okay,
Yeah,
bye.
thanks, Jessica. It was a fantastic question. And I think you've raised a massive issue that there is actually very little out there because exactly as you say, Dalitso, it's so hidden and so not talked about that, you know, we struggle, I think, as sort of global health community, if you like, to actually have effective things in place. And it has to be very localized in the community.
Yes.
It has to be really, you know, really speaking to that community and driven by that community. So, you know, it's something I'm so glad you're doing your PhD in this. It's such an important area. I think there are a few other ISA members who are doing, you know, different types of research, maybe different settings, but, you know, somehow similar lines. So we hope you'll keep on presenting to us as you go through your PhD. We'll accompany you on your journey.
I'd love that.
We really look forward to, you know, to seeing you get these out into the public domain and published and, you know, help to disseminate any publications that you do and your messages, of course. So we are at the hour and I don't see any more hands up. I don't know if there's anything else in the chat, just I think lots of thank yous. People probably have to jump off. So Dalitso, thank you so much. It was a really wonderful presentation. Another one to add to our wonderful ISA collection of presentations. So yeah, you'll be going up on YouTube and we'll be promoting it. So thank you and good luck with your PhD. We really look forward to hearing how it comes along. As I said, there are many other members doing, you know, similar types of research. So please do connect with them. Do have a look at the advocacy toolkit. Love to know if it's in any way helpful, you know, and to hear how you can put it into practice in the Malawian setting. So with that, a wonderful thank you. Thank you to everyone who's joined us and all your questions and comments. It's great to hear from you. And yes, we look forward to hearing more from you, Dalitso. Thank you so much.
Thank you, Paula. Thank you, everyone. Thanks. Bye-bye.
Great. Bye-bye. Thanks, everyone. Bye.
Bye-bye.